Yeah, so I am Manoj Tanwar, and I think thanks all for joining this particular session. And I am a neuroradiologist by training, and I do kind of AI research on the side. And the goal of this is to just kind of give some introduction to the field of radiomics, which is kind of extensive. And I have tried to keep it to the basics and kind of most relevant to like radiology residents or people with more clinical training. And yeah, so I think we'll just dive into this. And here are, let's see if this can, okay, so here are my disclosures. So the one thing I want to start with, and I think is I kind of want people to think about uh, why this talk. And I think so AI is something which is not new, and so this has existed for many years. And I think there has been times where there has been increased interest in AI, and there are times where people like nothing really happens. So there were times in 1973 where we call this AI winter, where there's not much going on, and then times come where there's this like increased interest, and which is kind of relevant for the new phase. And I think in 2012, I think we have this new technology, neural networks or deep learning, which got some attention. There were some breakthroughs related to AI, and I think more recently we are seeing some rise of Chat GPT or large language models. So the field has existed for many years, and I think and is relevant to like not get super excited, but also uh, kind of also feel good about future. So I think this is the hype cycle, and this doesn't just apply to AI, it applies to all new technologies. So in this particular case is AI. So there is whenever there's new technology, there is this increased hype, and which was related to like radiologists being replaced by AI, those kind of things. And then there is some disillusionment when things don't work the way people were expecting. And then but gradually there is always some value, and I think we will go over like how things can be valuable. So I think so the other thing is like, why do we need AI? And I think we have these excellent physicians who have worked really hard, and they are really good at what they do. So recently we published a study where we used a very uh, like commonly used AI method for detection of, for example, intracranial hemorrhage. So we tested this prospectively and on almost 9,000 studies and almost 7,000 patients. So what we found was the radiologists we did in two phases. So the first phase was like without AI, and the second phase was with AI. So the accuracy for ICA detection actually decreased. And so think about that. And I think one of the reason I want to kind of stress here that the performance of working in healthcare, the expectations are really high. So like even without the AI, and this is one particular study. So like I don't want to reject AI completely or a particular model or all those things, but the accuracy is very high. So the accuracy of radio without AI is like 99.5%. So if someone is performing at a level like that, it's really hard to kind of improve the performance. So, and the other thing we looked at was the mean turnaround time. For example, if we are a radiology without AI, it actually takes more time to crank out those reports. And the part of that was kind of related to another thing to look at. So, so I want you guys to think like what AI is. So it's not, and that's how I say this. This is a augmented intelligence where you're trying to improve the performance of what exactly you're already doing. And radiomics kind of uh, goes into the same domain. So I think this idea of augmented performance, and so like images have more information in them that human eye can see, and that's what the goal of radiomics is, to help radiologists do what they cannot do right now. So radiomics would is extraction of quantitative metrics or radiomics features which are in the images, and then we capture the various tissue and lesion characteristics, and we could make a radiomic model which could be based on the basis of just the imaging features, or they could be combined with demographic, histologic, genomic, or proteomic data. So the applications for radiomics, I think, are extensive, and I think a lot of work has been done in cancer. So some of the work which has been done is prediction of clinical outcomes or prognostication or uh, prediction of distant metastasis or assessment of cancer genetics or would the treatment respond to radiation therapy or separating out true progression from radiation necrosis or and there's some work in stroke and hydrocephalus and I will talk about those things. So this is a radiomics pipeline, and I think so. There are multiple steps in this pipeline. For example, the first step is image acquisition. This is an example showing, for example, hepatocellular carcinoma. So patient gets an MRI, and the MRI shows a mass in the right lung, and I think so. You have these sets of patients, and then we construct the data set, which would have, depending on the study and things you are trying to study. Uh, there will be exclusion criteria and inclusion criteria. And then once you have this data set, we anonymize those images and export those DICOM files and segment the various lesions of regions of interest. So then we extract the radiomic features, which are textural and features which we can extract, and then we use these things to form the prediction model, and this could be combined with other clinical data, lab data, to kind of predict the outcome that whatever the goal of your project is, which could be predicting the pathology or the therapeutic response or the survival. Now, this is another example of the radiomic workflow. For example, this is for lung cancer, and the workhorse here is the CT scan. So patient undergo a CT scan, which shows uh, various, I mean, there are two different patients, you see two different type of masses, and these are segmented, and then we extract various radiomic features such as shape analysis, histogram, or the texture, or features such as angiogenesis, like what's the vascularity of these masses, or a PET scan can give you a metabolic features. So we make a statistical model out of that, which could be, in this case, was used for like prediction of treatment outcomes. So now the question is, and I think the main question, like, what kind of images can you use for such analysis? So the images uh, could be essentially all the images we work with, which includes the X-ray or a CT scan or an MRI or a PET scan or an ultrasound. For example, like you could build a data set which has these lung masses on X-rays, or the CT scan would have this masses depending on the data you're working with, and both non-contrast and contrast enhanced MRI, and depending on the task. For example, someone can build a data set of TT weighted images for assessment of glioma patients, or similarly, you can use PET-CT images for example, this is showing a FDG mass in the right parotid gland, and I think, or if the goal is to kind of study breast cancer patients, there could be a mass like ultrasound of the breast. So data selection in any radiomics pipeline is a very key step, and I think it is very critical to select a representative sample for training if in order to do the task. And this is very similar to residency training. For example, if a resident has never had, or the program doesn't have a cardiac MRI rotation, for example, like it would be really hard for the graduates of the program to read a cardiac MRI in the job. Or if you have, or someone has never coiled an aneurysm, and if they are expected to do that in their first job, I mean, I think the chances of that working is going to be fairly low. So I think so training is really important. If whatever the task you want to give to the model, if you have not shown those type of images or those type of examples to the model would not probably work that well. And there are some models we do not require, like non-supervised model, but generally, I think it would be good to kind of have a representative sample of what you want and be cognizant of that diversity. For example, if the patients are coming from diverse group, then that should be built into the training set. And the other thing is a multi-site. For example, if all the data set came from Alabama, I mean, I think it would be kind of it. I mean, the chances of this working on a subjects from Sweden or Minnesota, I think is going to be. So it's always better to have multi-site data, and there's certain limitation, like it may not be super straightforward to kind of get data, and I'll talk about that later. So the next tag is segmentation. You have the images, you collected the data set, you anonymized everything. Now the segmentation could be done in multiple ways. And one of them is the manual, a radiologist, a resident, or a trained physician does that, or the other one is going to be automated. So there are advantages to both approaches. For example, like manual could be more precise, but it is time consuming, it could be expensive. The automated is cheaper if available, and I think, but they are prone to errors. Or someone can use a kind of a like a middle ground path, like use a semi-automated approach. So the task for this particular data set was segmentation of resection cavities. So uh, the patient, the initial images are on the left. So there's a resection cavity in the medial left temporal lobe. And then we had three approaches for the segmentation for this particular author. They published this in New Radiology. So the second one is a fully automatic approach. And the extreme right is a manual approach. So as you can see, I think there I mean, someone would want to like maybe segment out some other areas, and I think there may be some missing areas which could have been segmented, and there are some false positives which are not resection cavity, but they are in the brain parenchyma. So someone could go and kind of correct what the algorithm did, and will end up with a semi-automatic approach. So this is another task. In this case, the researchers were trying to segment out intracranial hemorrhage. And so these are the initial set of images, and the greens are the fully automated, and the blue are the manually annotated. So I think a lot of these tools are available, and I think it kind of varies from the task you have at hand. And I think some of these are free, some of these are paid. So I think depending on your budget and how well it works, someone can choose the approach and how many studies needs to be segmented, those kind of things. All right, so we segmented abnormality, then we would build a radiomics model which would extract radiomics features, and there are thousands of radiomics features which fall under various domains. For example, histogram features, texture, GLCM, and some of these words are fancy, and you can read up more about them if you want. And GLDZM or angiogenesis, or so the thing I'm trying to convey is there are more than one features, and it actually, for example, if you're working with a brain MRI and you are a human, I mean, you are working with a few sequences, T2-weighted flare. So the number of features for radiomics can extract is in thousands. So they just extract, they have more information to work with if the radiomics model works well. So once you have extracted this thousands of features, it is not efficient if you use all the features. So the model will predict out and like figure out what are the most predictive features, and which may be 10 of them or 20 of them, but the initial set of features which are extracted is in thousands. So for example, we want a feature which is the most predictable. It serves the purpose of the prediction the best, and also it's representative of the variability in your data. So there are various factors which influence the radiomic stability, and these can impact at various stages of the pipeline. For example, the image acquisition or reconstruction or segmentation, post-processing, feature extraction. I'll mention a few. For example, if you're working with MRI sequences like the field strength, if it's a 1.5 Tesla or 3 Tesla, and what's the slice thickness and reconstruction, what's the reconstruction technique that you're using, or the matrix size, is the segmentation done at 2D. 2D means like one slice, and 3D means like it's a 3D volume. And if there's an abnormality, you're segmenting a 3D volume. 2D, you are doing like slice by size, or if this automated or semi-automated. And the post-processing techniques such as image interpolation and pixel sizing, things like that. And the mathematical formula we use for like feature extraction. All right, so the features have been extracted. Now we have to make a prediction model and to predict whatever your goal is. And there are various machine learning approaches which could be used uh, for that. And I think data boost, decision tree, k-nearest neighbor. Some of the more common one recently have been like neural network or random forest or SVM. So it may depend on the task. And I think neural networks or I mean some of the random, I mean these are more popular because of the results, but it may depend on the task you're trying to do. Sometimes you can try a few more than one model and see which works best, and for the task you have at hand. So I will go over a few case scenarios. So, for example, this paper published in Radiology Artificial Intelligence. So they looked at the stage 3 and stage 4 cancer patients who were receiving platinum-based chemotherapy. So, like they applied exclusion criteria, and then they were mainly looking for responder and non-responder, and to try and separate out on the basis of pre-treatment images, can you like predict if the patient will respond to chemotherapy? And the images for this particular case were CT scans of stage 3 and 4 lung cancer, and there was feature extraction. And I think so what the study was like, not just the lesion. I mean, usually the tumor is the lesion that we see on the CT scan, but there is a area around the lesion which is also not normal. For example, if I give the GBM analogy, like there is a component which is enhancing, but there is this flare signal around it which is not entirely normal. So they used both like the lesion as well as the surrounding, uh, which I'll show you kind of the next slide. So yeah, I mean, so they use the lesion as well as the surrounding environment, which does impact, which were the features from both the areas were used for this particular one, and in underwent this feature selection, and then the analysis. And yeah, so I think so in radiology we are not trained to do this, and I think you look at a mass, and we kind of report the mass is located in right upper lobe or left lower lobe, and we give measurements. So we are not trained to say that this stage patient is going to respond to, and we comment on things such as solid or ground glass, those kind of things. So I think so they incorporated both the lesion and the surrounding areas. And so they found that they were overexpression of certain radiomic features, such as peritumor gabber or intratumor loss, which is a non-responder. And they were able to capture those differences using skewness, kurtosis, and they were able to achieve a EUC of zero point 0.8 in the training set and 0.77 in the independent set. And I think one of the key things which came out of this paper was like it's not just the lesion but also the environment which could be used. And I think and that's not how we work in radiology, at least now. Yes, so this was published by our group, and I think so. We looked into spontaneous basal ganglia expansion. So there are this patient which come with spontaneous basal ganglia hemorrhage, and I think if you are, I mean, I'm sure people have seen this. So, and these hemorrhages are really big, and I think there is some patients are known to like can expand, and they have known to have bad prognosis. And so there are some clinical signs, for example, like if there is some heterogeneity or a level, or there are some satellite lesions, those may be kind of at risk of worsening or increasing in size. So this particular study included only 18, more than 18, so adult patients, and they had a presentation CT scan and then a follow-up CT scan, so we could compare if there is growth. And I think we use manual segmentation of the CT scan, and we also have three neuroradiologists can evaluate the various signs, and we developed machine learning models for prediction of uh, the hematoma expansion. And so we found like if we were using just the clinical features or just using the radiomics features, actually when we used both the features, the performance, the AUC was highest. For example, like SVM AUC was zero point 0.8 for this particular task. Similarly, we did another study, kind of studying if someone can predict. So there there are a number of patients which have normal pressure, hydrocephalus, and the treatment of choice for these is putting a shunt to kind of divert the CSF uh, into either the peritoneum or like the atrium, and it's very hard to predict which of these patients are going to respond. And many times they respond, but many times they don't either. So we kind of use MRI images to kind of study if for example, this patient has this prominent ventricles when compared to the sulci and acute callosal, and obviously they have symptoms of like walking difficulties and things like those. So we build a radiomics model to predict if these patients would respond to that, and the CSF was segmented, and which was used to uh, kind of build the models. So I think so this one we just used the various clinical features and different models, and we saw the random forest just passed maybe 0.7. I think if we just use clinical judgment, I think it's probably like 50%, like kind of flip of a coin to see if the patient is going to respond or not. And uh, and these systems are not perfect. I mean, this is a research setting, so we are just testing the concept. And so yeah. So I think then we combine the clinical and radiomics features, and the performance improved. And I think generally, at least there's some value of combining both clinical and radiomic features. And I think so SVM did better here. And I think what I'm trying to say is like there it may vary which model may work best. And I think so it may be worth testing a few models. So what are the limitations? I mean, I think one thing I will say, like this is a research area and there are limitations right now. And one of the limitations is obviously like creating a robust data set. I mean, it's easy to create like 100 uh, patient data set, and I think and there are limitations around data sharing, as we talked about, like something which may work in Alabama or Massachusetts may not work in California. So I think having creating this robust data set, which is has all the represented patient group that we are working with. And the other thing is manual ground truth. Obviously, any machine learning model you could develop non-supervised approaches, but I think manual ground truth is primary for like development as well as testing. And the other one is a narrowly focused application. I mean, I think if a model works, for example, for meningioma, and I think so it's kind of really hard to, and there is some knowledge transfer, but it's really hard to kind of, these applications are very focused. And I think so if something was developed for NPH, I mean, I think you can't use this for maybe, I don't know, heart enlargement. Or if something was developed for lung cancer, I mean, it would not, it may not work well for like HCC. And sometimes there is some knowledge transfer, but they are very focused applications. The other thing would be pathological validation. I mean, I think pathology obviously the gold standard for a lot of things. For example, the type of the tumor, or is the tumor responding, those kind of things. So I think it would be kind of a uh, gradual validation that. And I think so the future direction is going to be like integration in imaging workflow, and that's going to be very selective. And I think if I have to guess, I think it would be kind of easiest in cancer imaging because we are already doing some uh, some extra analysis on those images. For example, in brain tumor, we're already doing this perfusion images. So I think you could imagine, and there are already software packages out there that you can have another package which can also do kind of radiomics. So I think I want to leave some time for questions, but I think, yeah, thank you very much. I think I'm happy to answer any questions.
Yeah, thank you so much, Dr. Tanwar. That was a really excellent presentation on a really, really complex topic. So if there are any questions, please feel free to put those in the Q&A box. But I did have a question, something that I've been wondering about, that in radiomics, you mentioned that cancer imaging is kind of a natural fit for some of these radiomics tools, but it's very challenging, right, with some of these especially some of the more rare cancers, to get enough power in your algorithm training. And one, we have different augmenting features, and we can flip images, we can put blurring filters. But do you have any thoughts on the use of generative AI to produce similar exams to augment the data, or the data training size?
No, I think some of the researchers have tried to like augment the training set, especially because it's not possible, as you said, like for certain like rare disease type, and it's like for example gag and those kind of things. And I think I think there's definitely some role for that, like especially in the research areas. And I think some of the tumors like are so common, for example, breast cancer or lung cancer, those kind of things. Like it maybe if enough institutions are able, like if they are willing to share data, those kind of things. I mean, we might be able to get to a good amount of data set. But for some rare stuff, I mean, obviously, I think like those kind of like creating some of the data set using AI, kind of bumping up the data, maybe a good approach, I think. Yeah.
Fantastic. Well, thank you so much for joining us today. If there are any additional questions, please feel free to put them in the Q&A. But we are coming up close to our time here, so I will pass it over to Dr. Samar, who will be presenting AI in cardiac imaging. So thank you so much, Dr. Tanwar.
Oh yeah, thanks, Dr. Parshi.